Wonderful. Thank you so much for the introduction, and I'm super excited to be here today. So my name is Ariella Shikanov, and I'm the founder of Artova, and our goal is to restore natural ovarian function for pediatric cancer survivors. So the problem that we're trying to solve is caused by anti-cancer therapies that include chemotherapy and also radiotherapy. Girls who have leukemia before puberty have to undergo anti-cancer treatment that include full body irradiation. And in 60% of these girls, the ovaries are damaged. As a result, they undergo premature ovarian insufficiency or POI, and they cannot undergo physiological puberty. So by the time they reach pubertal age, which is around age of 8 or 9, the ovaries are damaged and they cannot restart the process of maturation in adulthood. As a result, these girls end up with shorter stature, they're heavier, they have 75% more likely to have to suffer from a broken bone, they have higher chances of having a heart attack, and overall, it causes incremental in life healthcare cost. If you look at the picture of two women at the bottom of the slide, you probably will never guess that these women are identical twins. So identical twins. The woman on the right had leukemia when she was 3, and as a result, you can see all the effects of the premature ovarian insufficiency. So what is our competition, or basically what is available today to help these girls? It's a hormone replacement therapy, HRT, which was designed to treat postmenopausal symptoms. It's delivered as a sticker or a tablet or both, and then it delivers only 2 ovarian hormones, progesterone and estradiol, and they're delivered as a monotonal delivery. There's only certain consistent concentrations in the blood. And if you compare to ovarian milieu, hormonal milieu in a blood of a woman, of a healthy woman, over a period of 28 days, which is the menstrual cycle, you will see there's enormous fluctuation in the same hormone. So estrogen goes up and then decreases and then goes up again. And progesterone is also increases in the second part of the menstrual cycle. And it only shows you that there is a very significant crosstalk between the ovaries and the rest of the organs. So it's controlled by the brain. And when you just deliver HRT, you really do not mimic what's happening normally physiologically in the growing woman's body. So our solution, Artova's solution, is to take ovarian donor tissue. We take small pieces, encapsulate it in immuno-isolating capsules. It has to be immuno-isolated because it's coming from a healthy donor, so it's not rejected by the immune system. But then the capsule is made of hydrogel that would allow the tissue inside the capsule get stimulated by the circulating hormones, respond, and then secrete whatever normal ovary produces in a growing body in a normal physiological cycle. We envision this to be a subcutaneous implant. It's minimal invasive. It can go under the skin and the arm, similar to other contraceptive delivery tools. It's going to be self-regulating because we're using ovarian tissues to cells dynamically respond to circulating signals. We will use donor ovarian tissue, and one donor can produce hundreds of these kind of capsules. So we don't anticipate having limited supply. This capsule is going to be immuno-isolating, so we do not need to use any kind of immune suppression. And we also anticipate to have enhanced patient compliance because no stickers, no oral tablets are involved. And this is going to be implanted subcutaneously at least once a year. So our team at the University of Michigan, I'm the founder of this company. I've been working on this project for 15 years, also in my lab. Kate Remus, she's my business mentor. She's from the tech transfer office here at the University of Michigan, and she's been with me for many years now, helping me develop and bring this technology to the clinic. Colleen Flanagan, she's my research scientist. She's working in the lab, and she has more than 20 years working with startup companies and also taking this through the regulatory process. And then lastly, Molly Morovic, she's the director of the IVF clinic, and she's working with me also for more than 5 years on this project, and she agreed to lead our clinical trial once we get to this. So far I've been funded by the NIH to my group, so R01s. mostly. And by now we've developed this polyethylene glycol hydrogel capsule. We published extensively. We've been able to demonstrate the mouse ovarian tissue can function in the mouse for more than 60 days. This is how the capsules look with tissue. Once we completed all the possible experiments in mice, we also tested it in non-human primates, so rhesus monkeys. It was a smaller pilot study, but we've been able to show that this capsule can work in healthy monkeys. And lastly, and most excitingly, probably, we also established access to human ovaries, working with the organ procurement organizations. So we have healthy ovaries from donors delivered to our lab. We're using clinically approved protocol to dissect, cryopreserve, thaw, and implant these pieces of ovarian tissue in mice. We've performed extensive customer discovery. So we've done NSF-I course in 2019, and my business mentor, Kate, traveled with me, and we interviewed more than 200 physicians and family members, endocrinologists, OBGYNs, who all agreed that this is a really needed technology. We also performed interview of payers, so people who represented different insurance companies, and overall there was a positive enthusiasm for the device. Mostly we were interested to see how much the payers would pay for something like this. And although the range was pretty large, the average cost would be somewhere between $25,000 to $30,000 per year, which was very encouraging to us. In terms of market, so our target population is survivors of pediatric cancer who suffer from premature ovarian insufficiency. This would give us a pediatric orphan disease designation through the FDA. Right now in the United States, we have about 75,000 patients that suffer from this, who had cancer when they were young, and about 10,000 new patients adding every year. So kind of being pretty conservative, we're thinking if we can tap into 25% of the market, and then with the average price for this device, we're looking into $500 million per year. However, we also envision that there is a significant upside opportunity to treat women with premature ovarian insufficiency. So anyone before age of 50 who reach ovarian insufficiency can benefit from this technology. And obviously peri and postmenopausal women can get treatment using our device. But obviously as we expand to the market, we can adjust the pricing. In terms of intellectual property, we have one patent already holding, and we're submitting additional kind of bootleg patents to protect our technology. We envision that this device is going to be placed subcutaneously. This is another example of subcutaneous trocar. It's kind of inserted, and then the capsule would be sitting subcutaneously. There is already experience working with this kind of technology. And Molly, my clinical collaborator, she supports this kind of approach. In terms of regulatory pathway, we worked with two consulting firms, Biologic Consulting and Army. They helped us compile the draft for the first in human clinical trial. They confirmed that we will be regulated as a combinational product. We also received feedback from the FDA for the design of our proposed preclinical biocompatibility and toxicology studies. We already established CMC and SOP in terms of how we process this tissue, how we keep it, how we handle it, how we encapsulate it, and so on. In terms of where we are right now, so we anticipate to have clinical data within 3 years. The 2022 year we spent on manufacturing capsules for biocompatibility and toxicology test. We received $500,000 from the University of Michigan to complete our animal preclinical studies this year. So we've purchased all the GMP level excipients, we made these capsules, and then right now we are in the middle of doing our murine study at NAMSA. We also have the draft for the phase 1 clinical trial and the budget, and we're working on the MOOPs and DASP. So we're hoping to complete this by the end of 2022. And then our next goal is to complete IND enabling studies, submit a IND to the FDA, and then get it approved by the end of next year. Meanwhile, we are applying, so we have right now SBIR pending, and we're also thinking in terms of starting our $10 to $15 million fundraising in Series A. And then our goal is to initiate phase 1 clinical trial at the University of Michigan here by the end of 2023. And then next step would be to expand to multi-center phase 2, phase 3 studies. In terms of study design, the first study is going to be single center, open label. We will kind of recruit as many patients as possible, but up to 15. This is going to be the age distribution. We will implant increasing number of capsules to show safety and also efficiency. So why now? In summary, the pediatric cancer patients survive so much better and they live longer lives. So if we're having this conversation 40 years ago, many of these girls wouldn't even live long enough to reach puberty. Decades of research on cell encapsulation, such as islets, laid a strong foundation for this work, so I learned from the best. There is a growing demand for cell therapies, and also this is a cell-based therapy to address an urgent problem in women's health area, both for prepubertal patients and also postmenopausal women. And we also see it as a technology that can be used for other cell-based delivery proteins and peptides and also vaccines. This is my last slide.
Thank you so much. Judges, the floor is open for you. Jeff, go ahead.
Yeah, so this is awesome, and as a pediatrician, we ignore kids too much. First off, just so I remember to mention it, this is also another thing that PCORI might fund because it is an orphan disease, very patient-centered, so that's another possibility for you to go. What I was concerned about a little bit, though, is when we remove somebody's parathyroid and then we implant those under the skin, the feedback loop is a little bit inhibited, and I'm just wondering, you may run in, I would actually predict that you would run into something similar in terms of that feedback loop between your implanted cells and that central control. And because of that, I think you may have some issues. I don't know, I hope you don't. But if you go in one direction, you could end up having some safety issues like increase in DVT, gallbladder disease, da-da-da-da-da. And if you're too little, then you go on the other side of the spectrum. So I don't know if you've looked at any animal models to try and address that a little bit, but you likely should. And then the other question, you wrote that the kids were going to be, the adults were going to be 18 to 40. And I'm just going to say way too old. I know it's harder to do these things with kids, but 18 to 40, you missed your window you show the twin picture, right? If you did that once they were 18, the growth is already done. The growth hormone is out the door, and they're gonna look the same in the picture. So you kind of got to get in there a little bit earlier, as difficult as that is to do.
Awesome. So thank you. This is all correct, everything that you're saying. So in terms of tissue function, ovary is different. And I get a lot of, so you asked me about parathyroid. Most people ask me about islets, and ovary is very unique. So ovary has a certain cohort. And we've tested it in mice and in monkeys. So it is working, and because you have this continuous loop, it's different because ovary has a self-regulating action. It is also in terms of hormones that it makes, in terms of parathyroid hormone or insulin, it has to act immediately, right? You eat cake, you have to have insulin. In terms of estradiol and progesterone, if there's a small delay in the release, we don't anticipate to have any problems. So for your question about the phase 1 trial, this is correct. And so we chose, and this is kind of, we were advised by our advisors that this is the way to go in terms of safety. So first I need to show safety because it has never been done before. We're just showing safety. So these women will be POI, so they will not have any ovarian function. So you will be able to measure FSH and estradiol and other hormones. We will not see the effect on puberty, but it's a safer and better bet to start with adult women with premature ovarian insufficiency.
I think we can take one more question. I see your hand raised, Mitzi. You're on mute.
3 years in, you'd think I remember by now. So thank you for your presentation. You actually answered one of mine because I was worried that the market was too small, even though you are getting this pediatric orphan disease consideration. And with respect to looking at perimenopause and menopause, what would you need to do to ensure that you weren't falling into some of the same challenges. And again, I know that some of those have been debunked in terms of risk of cardiovascular disease and breast cancer.
So this is an excellent question. And I think one of the problem that we see that women who go on HRT, I think this device is going to be better. And because so women live so much longer, but we reach menopause exactly at the same age. So you have a significantly longer duration postmenopausal ages. And there's a lot of research coming out showing that HRT, the delivery of estradiol in HRT is so different from what we normally experience. So the effect on brain is so much different. In terms of safety, it wouldn't be more dangerous than HRT, but the physiological delivery of estradiol, I believe, would be better. And you deliver both estradiol and progesterone. And then with HRT, you have to take them separately, right? Because even women who have their uterus, they still have to continue taking progesterone, and progesterone is only oral delivery, and estradiol is better through the tapes, so the stickers. So there is a lot to learn about, and I'm way far from postmenopausal women. And I do think that the effect is going to be more significant in prepubertal girls, but I think there is a market and there is a lot to look at.
Right. And I think what you're talking about is, in terms of perimenopause, my guess is that the bar is going to be raised in terms of looking at some of those potential side effects or adverse effects.
Absolutely.
Thank you.